Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. It's been a little bit since we dropped a core content podcast. Decided to take the summer off, but we are back, and you should be seeing us in your podcast feed every other week. And we're going to start with a real banger this week on penetrating neck trauma. We actually covered this in a podcast back in 2019, but there are kind of some updates in management here that I thought were really important. And so for today, what we're going to focus on is three different areas. We're going to focus on airway. We're going to focus on hard signs, and we're going to focus on control of hemorrhage. Let's start with the airway. Patients with penetrating neck injuries can pose some significant anatomic challenges. Most of the airways that we deal with are more on the physiologic end, and you can see those with penetrating neck injuries as well, but it's the anatomic challenges that make these a bit unique. They can have bloody airways, there can be airway distortion from hematomas and air. All of these things make these intubations a little bit more difficult. We also do have to pay attention to those physiologic challenges: hypoxemia, hypotension, and acidosis. The key in managing penetrating neck airways is understanding that they're not all going to be the same. There are really three classes of airways that I consider. Number one is the emergency airway. Either the airway is obstructed or the patient is moving insufficient air for adequate oxygenation and ventilation, and these airways need to be taken immediately. There's a danger in waiting in these patients, especially if they have something like an expanding hematoma, if there's an obstruction or an anatomic challenge, because that can actually get worse with time. The second category are the semi-emergency airways. The airway is patent and the patient demonstrates adequate oxygenation and ventilation, but airway security over time is questionable based on the injury pattern. So for example, if the patient has a hematoma that seems to be increasing in size, they might be oxygenating and ventilating right now, they might have a patent airway right now, but in minutes that can disappear. And so once again, we want to take that airway pretty expeditiously. Finally, there is the delayed or elective airway group. The airway is patent, it's secure, but definitive control of that airway might be required because the patient is going to need something like procedural sedation, or the patient's going to have to be transferred either to the operating room or transferred out of your institution, and you're worried about losing that airway during that process. Once you decide that you're going to intubate the patient, we have to think about what is the best way to do this, and we often overcomplicate this in our head. If the patient doesn't have any clear signs of obvious distorted anatomy, then it's probably fine to just use your standard approach. If the patient is hemodynamically unstable, we know that RSI can kill that patient and we want to resuscitate prior to intubation as much as we can, understanding that we don't want to lose the anatomy of our airway. For many of these patients, I will do a standard rapid sequence intubation with a paralytic and an induction agent, of course making sure that I have all of my airway adjuncts available, and I'm going to go with a double setup and have someone ready to crike the patient if necessary. If the patient does have signs of distorted anatomy, then I'm going to vary my approach a little bit. And I don't want to use a paralytic if I can avoid it, because paralysis might change the airway anatomy even more. I might get more distortion, making it more difficult to pass a tube. In those patients, I will often go with a ketamine-only approach. I'm going to give ketamine just to relax the patient, make them more amenable to intubation, but I'm not going to give a paralytic because I want to maintain any airway anatomy that I currently have. And it bears repeating that regardless of which approach I am using primarily for intubation, I have somebody else ready to do a surgical airway, and that typically is going to be with a crike. Obviously, there's a lot of nuance in managing the airway of these patients, and you can't really express all of it in this kind of a format, but I think the key is to have an approach that you are comfortable with. Don't break out things that you don't usually do or you don't have familiarity with in these kind of situations. The next area to tackle today are the hard signs of injury. For decades, we used to teach the idea of the zones of the neck. Zones 1, 2, and 3, what structures lie in those zones, and that would dictate management. Depending on where the injury was externally, we would predict what could be injured below the surface, and that would tell us whether we were going to go to CT, whether we were going to go to the OR, or whether we were going to go to IR. But the zoned approach has a lot of issues, the biggest one being that you can't really tell what's injured underneath the surface based on where the penetrating trauma is. This is particularly true with gunshot wounds where bullets can ricochet, but it really holds for knife wounds as well, because a knife wound in zone 1 could cross into zone 2 or 3. And so we can't really predict the injury pattern. Instead, we go with the no zone approach, which is focused on hard signs of vascular and aerodigestive injury. The hard signs of vascular injury are shock without another cause, pulsatile bleeding, an expanding hematoma, an audible bruit, or signs of stroke, which is a vascular issue until proven otherwise in this setting. The hard signs for aerodigestive injury are airway compromise, a bubbling wound, extensive subcutaneous air, stridor, or significant hemoptysis or hematemesis. If the patient exhibits a hard sign of vascular or aerodigestive injury, they should be going either to the operating room or to the angio suite for intervention. Those patients are going to need to be intubated before they leave your care prior to them arriving in those destinations. That means that hard signs of vascular or aerodigestive injury, you're not going to CT, you're going to the OR, or you're going to angio. In the absence of any of those hard signs, we can look for soft signs of injury. These are things like non-expanding hematomas, hoarseness, dysphonia, a vascular bruit or thrill, or even crepitus. And in that group of patients, you're typically going to be going to CT angio of the neck to get a further assessment of what's injured underneath. Some of those patients might still need to be intubated, especially if they're not really cooperating with examination or the diagnostic modalities that are coming, but many of these patients can go and get that CT angio without controlling the airway. It's also good to remember that while your initial assessment may show you no hard signs, these injuries are dynamic, and 5 minutes later, that soft sign might have converted into a hard sign, so make sure to reassess your patients frequently. Finally, let's talk about management of hemorrhage. Unlike bleeding from an extremity, we can't just throw up a tourniquet in order to control the hemorrhage. This holds true not just for neck injuries, but also injuries to other junctional areas like the axilla and the groin. The key in getting control of hemorrhage in these circumstances is to apply a single finger to the area where the blood is coming from. What we see all too often is someone putting a wad of gauze in that area, pressing down on it with their whole hand. That's not an effective way to get hemorrhage control. That's really an effective way to hide the bleeding that is ongoing. You want to get control with a single finger to the area where the blood is coming from. Of course, there are circumstances where you can't do that. The bleeding is too deep, you can't get your finger into that spot, and we do have some fixes here. One of the best ones is placement of a Foley catheter. Take the Foley catheter, place it into the penetrating injury, and then you're going to inflate that balloon with either normal saline or lactated ringers or some other crystalloid fluid, and that's going to create a balloon tamponade on what is bleeding. This Foley catheter placement can be life-saving in junctional hemorrhage, whether it be the neck, the axilla, or the groin. And of course, while you're getting control of the bleeding, you also want to be giving the patient blood. So activate your massive hemorrhage protocol, which is going to be all of your blood products, tranexamic acid. All of these things are going to be helpful for the patient in order to bridge them to the operating room. All right, well, there you have it. A very quick overview of penetrating injuries, focusing on 3 areas. Number 1 is the airway, remembering that not all of these patients need to be intubated, but if you see any kind of a distortion of the anatomy, you're going to want to take that airway early before that distortion worsens. The second big take home is to avoid the zoned approach to the neck and think about the no zone approach, focusing on hard signs of aerodigestive and vascular injury. If you see a hard sign, you're going to bypass CT. That patient should be going directly to the operating room or the angio suite for continued management, and you're probably going to need to intubate that patient before they go off in that direction. And then finally, don't forget about hemorrhage control. The best way to do this is with a single finger to stop the bleeding, not a wad of gauze. If you can't reach that site of bleeding, consider placement of a Foley catheter and inflating that balloon to create a balloon tamponade. That's all for the Rebel Core Content Podcast this week. We'll be back in 2 weeks for another cast. Until then, don't forget to pop on over the site, check out all the fantastic posts from our faculty, and until next time, stay safe.